Well, hi there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach nursing concepts and share tips on how to thrive in nursing school and beyond that at the bedside. Today, we're diving into a pediatrics topic and focusing specifically on some key things to know about pediatric clinicals. Now, before we do that, let's take a quick minute for our listener shout out. And this one goes out to Alicia, who says this. I recently completed the Crucial Concepts Bootcamp, and it consisted of effective communication and deep expertise. Nurse Mo has amazing presentation skills with a confident and articulate delivery that kept me engaged. She provided valuable insights, including relevant examples and case studies that contextualized the information. I've tried other membership platforms and podcasts, and Mo's courses are the best. Well, Alicia, thank you so much for that fabulous feedback on Crucial Concepts Bootcamp, and I sincerely hope that it enabled you to start nursing school feeling confident and like you are ready for absolutely anything. So if you're curious what Alicia is talking about, she's talking about my nursing school prep course, Crucial Concepts Bootcamp, which teaches, obviously, some crucial concepts, some really important things that set you up for nursing school success. It's absolutely fantastic for students who are starting nursing school, and it's even fabulous for students who maybe had a bit of a rough start and want to come back into their second or even third semester a lot stronger. I'll put a link in the episode notes so that you can check it out, or you can go to straightanursingstudent.com/bootcamp. All right, so today we're talking about Pediatric Clinical and 6 key things to know before you step foot onto that pediatric unit. So the reason you want to do a little bit of advanced preview of pediatric clinicals is because they really are so very different from adult Med-Surg clinicals. And I want you to get the absolute most that you can out of this incredible and really valuable experience. So one of the first things to really understand about Peds Clinical is that it's really important to know pediatric developmental stages. A really big part of the nursing care of children is customizing your plan and your approach and your priorities based on the child's developmental stage. And this is where Erickson's 8 stages of psychosocial development come into play. And you'll learn about these in your PEDS class. So the 8 stages are trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, industry versus inferiority, and identity versus role confusion. And then that was just 5, I realized. I said 8. The other 3 are for older individuals, for young adults, middle-aged adults, and older adults. But these 5 all relate to children. So let's go through each of these and how they could impact your nursing care. So first is trust versus mistrust. And this occurs from infancy to about 18 months of age. And in this stage, guess what? The child does not trust you. The child is not going to trust strangers. And they're going to mainly trust their consistent caregivers, which in most cases are their parents. So in the hospital setting, one thing that you could incorporate into your practice, and this is probably going to show up on exams, is that children of this age benefit from caregiver consistency. So if you can have the same nurses working with the child, they can learn to get to know that person, learn to trust them, rather than having a different nurse every single day. Another thing that you can do to help recognize the child's developmental stage is to allow them to sit on their parent's lap whenever possible. Let's say you need to do some vital signs on the child. You wouldn't want to take the child from their parent and hold them while you do their vital signs or sit them in a chair by themselves. They're not going to be down with that. Let them sit on their parent's lap absolutely whenever possible. You'll get a lot more cooperation from the child. They won't be scared. Hopefully they won't be crying, maybe not crying as much if you do that. Again, they're going to want to be with that person that they trust. And another thing that you can do, very important, and this will definitely show up on an exam, is the importance of responding to the child's cues, namely their crying cues. When you respond to their crying cues, they learn that they are going to get consistent care, consistent attention, and their needs are going to be met. This helps them feel secure and learn to trust you. And then, even when the child's not crying, continuing to provide very consistent care, very consistent attention also plays a big part in getting the child to trust you and feel secure. So that was trust versus mistrust. And then about 18 months to 3 years, which are considered like the toddler years, the psychosocial stage of autonomy versus shame and doubt comes into play. And in this stage, really important to understand that the child is learning to exert their independence. If you've ever met a toddler, you know how strong-willed they can be. That's what they're supposed to be doing at this stage in their development. So a good thing to do here is to give the child options when options exist, so they do feel a sense of control. For example, you could say to the child, would you like to get your blood pressure on this arm or this one? Of course, depending on the age of the child. And if the child points to their left arm, then you do the blood pressure on the left arm. Really important here, though, that you don't give options when they don't exist, because doing so would really undermine the child's trust that they are giving to you and undermine their ability to have some autonomy and independence. All right, the next psychosocial developmental stage is initiative versus guilt. And this is going to be that preschool age child, about age 3 to age 5. And a child at this age is developing that sense of purpose and learning to do things with more independence. If you've ever seen a child in this age dress themselves, then you know what I'm talking about, right? They love to choose their outfits, and they sometimes come up with some really fabulous combinations. And I love it when parents let their kids wear whatever the child chooses, because it's just an easy way to let them have some independence. So an easy way to incorporate this into your nursing practice is to maybe give the child some small tasks that they can do, and also praise their accomplishments or their ability to perform those tasks. For example, you could say, now hold the stethoscope right here so I can listen to your heart. And then that involves them in the assessment. It gives them something to do. They feel important and they feel that sense of purpose. Next is going to be that school age child, about age 6 to 11. And this psychosocial developmental stage is called industry versus inferiority. And really important here to help the child feel productive, as they are focusing a lot at this stage on learning and feeling capable. So you want to help the child feel they are progressing and learning. For example, you might say, tell me what you've learned to do when your blood sugar is low. Something like that, something that they've learned about their care of their own, maybe their own chronic illness. Have them show you what they've learned. You also want to let the child help with procedures and assessments, giving them small tasks that they can complete successfully. For example, how about maybe with a child, a little bit on the older side, maybe 7, 8, 9, or 10. I'm going to have you hand me supplies while I change this dressing. Now, that's only going to work if the dressing change isn't painful, right? If it's a painful dressing change, I probably wouldn't have the child be helping me with that. I would find something else for them to help me with. But if it's an easy dressing change, maybe you're changing the dressing around their peg tube. That's easy. That's not going to hurt. So you could have them hand you your supplies as you need them. You also want to provide the child with positive feedback throughout their plan of care as you're working with them. And another important thing is, if the child is well enough to do their schoolwork, they will feel a lot of accomplishment and productivity if they have some space and time and energy to do that. So you might want to cluster that or work that into your plan of care. And then the last one, covering the children's psychosocial developmental stages, occurs in that adolescent, which is about age 12 to 20. And that is identity versus role confusion. And children in this stage are going through a lot of physical changes and a lot of changes with how they see themselves and how they see themselves fitting into the world. And the adolescent is developing their self-confidence in this stage and their self-esteem. Something you can do in this stage is provide same-age support groups or bring their friends in. That would also be really important for them to be with their peers. These types of things, highly, highly beneficial at this stage. So a few other things to take into consideration that kind of correlate with Erickson would be for toddlers, they really fear separation. Separation from their parents, being alone, being in the dark, those types of things. So if you can alleviate those or mitigate those fears, that will help tremendously. For preschoolers, again, about age 3 to 5, they really have a big fear of body mutilation. They are fearful of separation in the same way that toddlers are, maybe not quite as much, but in some cases, I mean, you've seen some children age 3 who are very afraid of being away from their parents. They fear pain. They fear upcoming pain. This would not be the child that you're going to tell, I'm going to come back and give you a shot after lunch, because they're going to be fearful of that the whole time. So you wouldn't want to prolong that fear about that pain. They're going to be fearful of blood and fearful of the unknown. Children at this age also have magical thinking. They might think that something they did caused their illness, or that if you poke them with a needle, their insides are going to leak out. That's very, very normal. You want to provide very simple explanations to children of this age in words they can understand, and opportunities for the child to take out their aggressions. A lot of that fear could turn into aggressive display, I guess is one way to say it. And a great option here is get them into the playroom, give them some Play-Doh or a ball or something that they can really get into and work out those aggressions. And then school-age children, about 6 to 12 years of age, are also very concerned with body mutilation, alterations to their body, and very, very concerned with potential harm, while also fearing a loss of status with their peers. Children this age will also often name their long-term devices, like if they have a PICC line for a long time, or a central line, or a PEG tube, they may name them as a way to personalize them. So you want to encourage that whenever it's appropriate. You want to allow school-age children to have as much freedom of movement and independence as feasible. A great place for them to go is the playroom. It's great for children of all ages. School-age children can really benefit from therapeutic play in the playroom. And just a quick note about the playroom, that is a sacred space in the pediatric hospital ward. There are no meds given in the playroom. There are no assessments, no vitals done, nothing unpleasant. The playroom is for good times only. You want to keep this as a safe place for children. And then adolescents have significant concerns about body image and concerns about social isolation. Allowing friends to visit, allowing friends to bring food in if that's appropriate is really helpful for an adolescent. In addition, you want to ensure adolescents have privacy as appropriate, because I don't know if you remember being 13, but I would have rather, oh my gosh, had my foot gnawed off by a rabid dog than change into my gym clothes in front of everybody, right? So you want to allow adolescents a lot of privacy when it's safe to do so. Okay, so that is a brief overview of developmental stages and then some other kind of psychosocial things to keep in mind about children when you're working with them in the pediatric clinical setting. The next item is pediatric vital signs. So one thing you will notice very quickly, if you haven't already, is that pediatric vital signs vary widely depending on the age of the child. And unfortunately, this is just something you have to memorize. So make some flashcards and memorize that heart rate, those respiratory rates, the blood pressure. Now, there is a really down and dirty estimation of hypotension that we use in PALS, or Pediatric Advanced Life Support, to determine if a child is hypotensive based on their age. So you would take the child's blood pressure and then do a quick calculation of taking the child's age and multiplying that times 2 and adding 70. And if their blood pressure was below that amount, that is considered hypotension that's going to require some further evaluation and treatment. Note that this is really only used for children aged 1 to 10 years old. So it's not going to be for your infants, for example, or your older children. It's just kind of a down and dirty way. If you are out in the field working with children, you're a first responder, or you're in the emergency room and you just have to quickly decide, is this child hypotensive? That's one way to do it. But you really need to know all of the reference ranges, heart rate, respiratory rate, and blood pressure for children in all age ranges. So make some flashcards and start memorizing those. All right, the number 3 thing to know about pediatric clinicals is knowing how to do weight-based drug calculations and formula calculations. So it's really important to take some time to brush on those things before you take your math exam for pediatrics, because if your school is like mine, you have that math exam early on in the semester and you get maybe 2, maybe 3 attempts to score pretty high, 90%, 95%, at some schools, 100%. And if you don't, then it's goodbye. So this is a high stakes exam. You need to know how to do weight-based drug calculations and formula calculations. So the reason we use weight-based calculations a lot in pediatrics is because children vary widely in size. So many medications are going to be dosed by weight. So if you're not sure what that might look like, here is an example of a weight-based dosage calculations problem. You're caring for a child after an appendectomy who is complaining of moderate pain. The MD has ordered acetaminophen at 15 milligrams per kilogram. The child weighs 48 pounds and the medication comes in a concentration of 10 milligrams per mil. How many total milligrams and total mils will the child receive? So if you want to do the math on that, round that to the nearest tenth. The answer is going to be 327.3 milligrams and 32.7 mils. So that would be an example of a weight-based dosage calculations problem, a pretty common and basic one. And then formula type calculations will ask you to dilute formula or tube feeding to a specific percentage. Here's an example of how this type of problem might look, either a specific percentage or a specific strength. So here's an example. The MD has ordered 60 mils of Pediacare formula to be administered at 2/3 strength. How much formula and water will you use to create the proper dilution? So if you want to give that one a try, go ahead, give it a try. The answer is that you will use 40 mils Pediacare formula and 20 mils water to arrive at that 60 mils at 2/3 strength. So if you're struggling with questions like this, and it's okay if you are, you're a student, and a lot of times we are struggling or pushing ourselves right up to the edge of our ability. That's how you grow. That's how you learn. So it's okay to struggle. Don't be scared. But if you are struggling with dosage calculations, I want you to take a deep breath because I have got you covered in my dosage calculations program called Confident Calculations. Now, if you are in Crucial Concepts Bootcamp or want to go that route, just know that all the lessons from Confident Calculations are included inside Bootcamp, so you don't have to get both programs. I teach a step-by-step, foolproof way to always get to the right answer with your dosage calculations questions in this program. I will put a link to it in the episode notes so that you can check it out. All right, before we dive into the next key thing to know about pediatric clinicals, which is the key differences in an adult and pediatric airway, let's take a quick little pause. I recently went camping, and the most important things on my packing list were bathing suit, sun hat, and of course, some wine to share with my fellow campers. And with my wines from First Leaf, that last part was so easy. I grabbed a couple of bottles from my fridge, and since they were from First Leaf, I knew they were going to be good. And that's because First Leaf isn't your standard wine club. It's so much better. Instead of getting what a standard wine club is promoting that month, I get a personalized selection that is customized just for me and my tastes. So I know I'm always going to enjoy the wines that First Leaf hand picks for me, like the Wisdom Point Grenache Rosé from South Africa. So refreshing on a hot summer day. Plus, I really love that I can tailor my membership, choose 6 or 12 bottles, determine how many reds or whites I want, and even select a shipping window that works for me. Now, we did an impromptu wine tasting on the camping trip, and I have to say, the wines I brought from First Leaf were clear winners, and now everyone thinks I'm some kind of wine genius. I'm not actually a wine genius, I'm just a First Leaf member, and you can be too. Get wines to sip and share all summer long with First Leaf. Go to tryfirstleaf.com/nursemo to sign up, and you'll get your first 6 hand-picked bottles for just $44.95. That's tryfirstleaf.com/nursemo. tryfirstleaf.com/nursemo. So another thing to know about Pediatric Clinical is that there's a lot of difference between that child-sized airway and the adult-sized airway. And the reason this is so crucial is because respiratory compromise is one of the key reasons children code. So we have to take respiratory very, very seriously. So the significant differences include the size. The pediatric airway is much smaller in both diameter and length. Its position. So in peds, the larynx is located more toward the anterior than in adults. And its shape. The airway in a child narrows at the cricoid ring, whereas in adults, it's more narrow at the vocal cord. So the shape is a bit different. The other big difference is the size of the tongue, which is relatively larger in the oropharynx in children than it is in an adult, making occlusion more likely and intubation more difficult. So the main issue that you will come across or be dealing with in children as it relates to their airway is that short and narrow airway. Imagine a newborn, tiny little baby, having an average internal tracheal diameter of just 2.5 millimeters. Think about how tiny that is. There is not much room there for airway edema of any kind or obstruction of any size. Even a small obstruction will greatly increase airflow resistance, putting that little patient at risk for respiratory distress and respiratory failure. Now, as the child gets older and grows, the tracheal diameter increases. By age 1, it's about 4.5 millimeters. By age 6, it's getting closer up to 6 millimeters in diameter. And by 14 years of age, it's at or approaching adult sizes of approximately 8 millimeters diameter. Now, pediatric patients also have physiological differences that make them more prone to respiratory distress and respiratory failure. For starters, infants have significantly higher oxygen consumption than adults do. And one study that I saw showed that an infant's demands of oxygen are at 6 mils per kilogram per minute versus just 3 mils per kilogram per minute in an adult. So much higher oxygen consumption. Further, infants have lower functional residual capacity, which is the amount of air left in the lungs after an exhalation. So even brief periods of apnea can cause an infant to desaturate much, much more quickly. Also, from my observation of pediatric patients, they do tend to decompensate quickly. They can compensate quite well for shorter periods of time, but when they crump or when they decompensate, they do it drastically. So any pediatric respiratory distress should be viewed as an urgent situation and requires very close monitoring and super fast expert intervention. So those are the key things to know so that when you're working with kids, I want you to have an understanding of how different their airway is from an adult, and also the fact that when they are in respiratory compromise, they can chug along and compensate and maybe look okay for a bit, but that doesn't mean you have a ton of time. When they decompensate, it can happen in spectacular and devastating fashion. So you have to be on this very, very quickly. All right, the number fifth thing, and this is related, is to know what a child in distress looks like or could look like. So, when you think about a young child, even if you don't have children of your own, you've been around young children. You know that they are naturally curious about their environment and the people around them, and they're always getting into things and touching things, right? So, that's what a normal child does and looks like. So, one of the first things to assess in your young patients is how alert and how responsive they are to their environment. If the child is engaging with others, moving around, acting curious, grabbing things, getting into things, being a kid, they're generally probably not in distress. However, let's say you have a child who's 2 years old and is listless and not moving around, not trying to explore or crawl around, or I guess a child who's 2 would be walking, right? It tells you how well I know kids, right? Who's not getting into things and grabbing at, your stethoscope or things in their environment, is going to tell you that this child is likely very ill and you need to take them very, very seriously. Children are really great at self-regulating their activity. When they're sick, they don't move around as much. They're conserving their energy. They don't feel well. And when they feel better, they get up and move and they play and they start interacting more. So get used to looking at how alert and responsive your child is to their environment. And then some general signs of distress in a child are going to be things like nasal flaring, accessory muscle use, grunting, stridor, and cyanosis. These would all be related to a child with impending or current respiratory failure. Remember, children can compensate for a while, but then when they can't anymore, they go down very, very quickly. So if you see any hints that your child is in any kind of distress, whether they are lethargic or using accessory muscles, you got to get help for that child immediately. That is what a child in distress looks like. Now, of course, it can vary depending on what's going on with the child. Those are just some broad things to look at, and I wanted you to be aware of them. All right, the last thing to know about pediatric clinicals is that you should understand and anticipate that assessing a child is very different from assessing an adult. So I would say assessing an adult, pretty easy. In most cases, adults cooperate with assessments. Even cranky adults will more or less cooperate with assessments. But children naturally avoid strangers and naturally avoid irritating stimulation, right? Plus, they're moving around a lot. They've got short attention spans. It's really hard to get a temperature on a child who won't open their mouth and cooperate, or get a blood pressure on a child who won't hold still, right? Or a child that doesn't want to engage with you and wants to go engage with the, medical supplies that are on the other side of the room. So really challenging in that regard. So if your assessment is taking a long time, the child's likely to become distracted and want to move on to do something more interesting. So with that said, here's a few tips for assessing and doing your vital signs on children. So first off, you want to incorporate play and fun and silliness as much as you can as appropriate for the child's age and their clinical situation. You're not goofing around and doing funny voices for your child who is septic, right, with a very low blood pressure. But you're taking vital signs on your more or less well child. You can get goofy, have fun with them, get them to think of it as a fun game. You might get some more cooperation. You want to involve the child as much as possible, and that will depend on their age and how good they feel, right? You want to let the child touch and explore equipment, like a stethoscope, for example. Let them get familiar with it before you place it on their body. And I would also advise you to start with the least irritating assessment and move toward the most irritating. And this usually means blood pressure last, and looking in their ears. That's kind of annoying. Maybe doing that towards the end. And then if you don't have a temporal thermometer and you have to use the one that goes in the mouth, they also hate that. So doing that, maybe towards the end. If you do the really irritating things first, they may revolt, right? And not participate with any of it. You could also break the assessment up into small chunks, maybe do part of it this time you go in the room, and then, a little bit later you go back in the room, fresh start and do the other things. Do that when it's feasible. If you need to get a full set of vitals and a full assessment right now because of the child's clinical situation, of course, you're going to prioritize that. And then let's say you do have a very sick child. You're going to start with the most critical assessments first. In a lot of cases, this is going to be respiratory, but each child's unique situation must be taken into account depending on what's going on with them. And I would say that's true for adults as well. When they're very sick, you're going to prioritize and look at their most critical assessments first and then work your way down to the less serious ones. So I hope these tips help you enter your pediatric clinicals feeling way more prepared and more confident and excited, because Peds Clinical can be really, really fun. Most of all, I want you to remember to embrace the unexpected, be flexible, and most of all, have fun. Again, if you're nervous about your dosage calculations for peds, because it does add an extra layer of complexity with the weight-based calculations and those formula dilutions, then you owe it to yourself to walk into that exam absolutely crushing your confidence level, feeling really good, and you can do that with Confident Calculations, which is my program that teaches you how to do dosage calculations with 100% accuracy. I will put a link in the episode notes to that, or you can just go to straightanursingstudent.com and click on courses in the top menu bar. And of course, I hope to see you back here next week for more tips and advice for thriving in nursing school. See you soon. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.